Ejaculation frequency in older men connects to prostate health, hormone regulation, and sleep quality in ways most men have never had explained clearly. Research on this topic exists, but it's frequently exaggerated in either direction online. Today, we're reviewing what the evidence actually shows, what remains uncertain, and what genuinely matters for men who've gone without for an extended period. A large, frequently cited population study following men over multiple decades found men reporting higher ejaculation frequency, generally 21 or more times monthly during certain adult years, had a measurably lower association with prostate cancer risk later in life compared to men with consistently lower frequency. This represents association from large observational data, not confirmed direct causation from randomized trials. Proposed mechanisms include clearance of prostatic fluid and reduced inflammation in prostate tissue, though these mechanisms remain incompletely confirmed in humans. Before continuing, a brief note. Nothing in this video suggests a specific frequency is required or that abstinence causes harm on its own in healthy men. The research discussed reflects population patterns, not individual guarantees. A common online claim suggests extended abstinence significantly raises testosterone. Some small studies found a modest temporary increase after several days without ejaculation, but this effect is small, inconsistent across individuals, and doesn't translate into a meaningfully different long-term hormonal baseline. Testosterone regulation depends on a feedback system involving the brain and testes, not primarily on ejaculation frequency itself. Nocturnal erections occur automatically during REM sleep, largely independent of a man's activity level, meaning erectile tissue generally continues receiving regular blood flow during extended periods without ejaculation. This means healthy men experiencing extended absence generally don't experience the tissue decline sometimes implied online, provided underlying vascular and neurological health remains otherwise normal. Men with conditions specifically affecting nocturnal erections, such as significant sleep apnea, reducing REM sleep, represent a different, more clinically relevant scenario. We're now roughly halfway through, and this is where population research gives way to more individual factors, mood, medication, and underlying health, particularly relevant for elderly men specifically. Ejaculation triggers oxytocin and prolactin release associated with measurable stress reduction and mood improvement afterward. Extended absence removes this specific input, though effects vary considerably between individuals. Some men notice little difference, particularly with other stress outlets active. Others notice increased irritability, more likely in men already managing chronic stress with fewer alternative coping mechanisms. Prolactin release following ejaculation is associated with improved sleep onset for many men. During extended absence, some men notice a subtle change in falling asleep, though this effect is generally modest compared to larger factors affecting sleep quality: stress, screen exposure, caffeine intake. Before continuing, if you want a broader framework connecting hormonal health, sleep and vitality after 40, Dr. Emily Carter's guide, The Iron Age, The Complete Blueprint to Reclaiming Testosterone, Strength, and Vitality After 40, covers testosterone, strength, energy, and vitality across 9 focused chapters in a concise 14-page format. It's priced at $49.99. With the link provided with this video, it's educational, not a replacement for medical care, but it offers a clear framework for understanding these interconnected systems. For elderly men, reduced frequency is often circumstantial, health changes, medication, relationship status, rather than concerning on its own. A change accompanied by other symptoms, fatigue, low mood, reduced motivation, warrants attention, since it may reflect low testosterone, depression, or an underlying condition rather than simply circumstance. Several conditions common in elderly men directly affect this area. Prostate surgery, depending on type, can affect function through nerve and blood vessel effects. Certain medications, particularly some blood pressure drugs and antidepressants, are documented to reduce interest or function as a side effect. Diabetes affects nerve and blood vessel function relevant here. Any of these, when identified as the cause, often have management options worth discussing directly with a doctor. Radical prostatectomy performed for prostate cancer can affect the nerves and blood vessels responsible for erectile function, depending on whether nerve-sparing techniques were used and individual healing patterns. This is a well-documented, expected possible outcome discussed as part of standard preoperative counseling. Function sometimes improves gradually over months to a couple of years following the procedure as nerve tissue heals, particularly with rehabilitation approaches sometimes recommended by urologists specifically for this purpose. Depression deserves particular attention in elderly men, since it's relatively common and frequently underdiagnosed, partly because symptoms present differently than the classic presentation: less overt sadness, more frequently fatigue, withdrawal, and reduced motivation across previously enjoyed activities generally. Reduced interest tied to depression is genuinely treatable, worth distinguishing from simple age-related change rather than assuming reduced interest automatically reflects normal aging. Given how many medications commonly prescribed to elderly men carry documented effects here, requesting a straightforward medication review with a doctor or pharmacist represents a practical, low-effort starting point. This involves reviewing a current medication list specifically for known effects on function, mood, or hormone levels. Pharmacists specifically are an underused resource for this kind of review, given their detailed knowledge of side effect profiles. Testosterone testing provides useful information, though testosterone naturally declines gradually with age, meaning a modestly lower level isn't automatically the explanation for any specific change, particularly without other symptoms of low testosterone specifically. Thyroid function and blood sugar testing can identify other relevant treatable factors. Blood work generally cannot fully capture psychological factors like depression, meaning normal results don't rule out these equally legitimate categories of explanation, bringing this together. Extended absence isn't physically dangerous and doesn't meaningfully raise testosterone or cause tissue damage in most healthy men, since nocturnal erections continue providing regular tissue activity regardless. It may affect mood and stress regulation for some men, though this varies considerably. The clearest evidence-supported concern relates to very long-term, sustained absence over years, specifically in relation to prostate health research, not shorter-term gaps. A change accompanied by fatigue, low mood, or other symptoms warrants medical evaluation rather than assumption that age explains everything. For elderly men currently in a relationship experiencing change in this area, communication with a partner matters considerably for how that change is navigated emotionally, separate from any medical evaluation pursued. Research on long-term couples finds partners who discuss changes openly, understanding them as normal and expected rather than personal rejection, report considerably less relationship strain than couples who avoid the topic entirely. A partner unaware of an underlying medical cause may misinterpret a change as reduced affection specifically toward her, when the actual explanation is entirely unrelated to the relationship itself. For elderly men who are widowed, divorced, or otherwise without a current partner, circumstantial absence differs entirely from a partnered man experiencing change within an ongoing relationship, and this doesn't reflect any physical or hormonal problem, simply a change in life circumstances. Research on loneliness in elderly populations finds meaningful associations with both physical and mental health outcomes independent of this specific topic, meaning maintaining other forms of social connection, friendships, family relationships, community involvement carries genuine, independently documented health value worth prioritizing regardless of this specific circumstance. It's worth addressing a pattern that sometimes develops in men who've become aware of this research: excessive self-monitoring, treating every fluctuation as a potential red flag. Normal variation exists here just as it does in appetite or energy levels generally. The guidance throughout this video applies most usefully to sustained, meaningful shifts, particularly those accompanied by other symptoms, rather than day-to-day variation, which is entirely normal. Excessive vigilance itself can become a source of anxiety that ironically contributes to the very stress response known to affect this area negatively. For elderly men whose blood work confirms genuinely low testosterone alongside relevant symptoms, testosterone replacement therapy sometimes becomes part of the conversation with a doctor. This isn't automatic based on a modestly lower number alone, since testosterone naturally declines with age. Clinical guidelines generally reserve this treatment for men with both consistently low levels on repeated testing and clear, relevant symptoms. It carries its own considerations worth discussing directly, including effects on prostate health and cardiovascular risk factors, requiring ongoing monitoring rather than being a simple, risk-free intervention. Nutrition connects to testosterone, vascular health, and general energy. Adequate protein intake becomes increasingly important with age to counteract natural muscle loss. Zinc and vitamin D, both sometimes deficient in elderly populations, connect directly to testosterone regulation, worth checking through blood work if broader evaluation is already underway. Physical activity remains genuinely modifiable regardless of age, with research finding meaningful benefit even when activity begins later in life, not limited to men who've maintained consistent activity throughout earlier decades. Some elderly men experience minimal change in this area well into advanced age without any specific intervention, reflecting genuine individual variation tied to genetics and overall health maintenance throughout life. This isn't the expected outcome for every man, but it's a normal, documented pattern worth mentioning so men experiencing more typical age-related change don't assume something is uniquely wrong with them. Bringing together the practical guidance discussed throughout this video, review current medications with a doctor or pharmacist for known relevant effects, request basic blood work covering testosterone, thyroid function, and blood sugar if a meaningful change has occurred, consider whether mood or broader life stress might be contributing factors, maintain physical activity appropriate to individual capability, and communicate openly with a partner about any changes rather than allowing assumption to create unnecessary distance. Stroke and certain other neurological conditions can affect function through their impact on nerve signaling, and in some cases through effects on mood and motivation more broadly. The specific effect varies considerably depending on which area of the brain or nervous system was affected, meaning generalized statements don't apply uniformly to every individual case. For men recovering from stroke, this is a reasonable topic to raise with the neurological or rehabilitation team managing recovery. Since it connects to broader recovery goals and quality of life considerations, rehabilitation specialists are generally well equipped to address directly, even though it's not always raised proactively by patients or care teams. Reflecting the same within geriatric medicine specifically, quality of life assessment increasingly recognizes this general topic as a legitimate component worth including in comprehensive care, moving away from an assumption that it becomes irrelevant once a patient reaches a certain age. Geriatricians increasingly incorporate direct, comfortable questions about this general area into routine health assessments, recognizing its genuine connection to overall well-being and mood, rather than treating it as a topic patients must raise entirely on their own initiative, given how much cultural reluctance still surrounds the subject for many patients in this age group specifically. Alcohol deserves specific mention since its effects are frequently misunderstood. In small amounts, alcohol can temporarily reduce inhibition. Physiologically, alcohol is a depressant that directly impairs blood flow regulation and nervous system signaling, meaning regular or heavier consumption is well documented to reduce function over time, separate from any effect on interest. Chronic, heavier alcohol use also independently lowers testosterone through effects on the liver's hormone metabolism. A man noticing gradual change alongside regular, heavier drinking has a genuinely identifiable, modifiable factor worth addressing directly, often producing noticeable improvement within weeks of meaningfully reducing intake. Smoking carries similarly well-documented relevance, given its established impact on blood vessel health throughout the body. Nicotine constricts blood vessels, contributing directly to the same arterial changes discussed earlier regarding cardiovascular disease and function specifically. Research consistently finds smokers experience measurably higher rates of difficulty compared to non-smokers of the same age, an effect that improves, sometimes substantially, following smoking cessation, since blood vessel function shows genuine capacity to improve once the ongoing damage from smoking stops. This connects to a broader pattern discussed across multiple topics on this channel. Many men delay raising concerns in this category with their doctor, whether due to discomfort or simply not realizing a symptom is medically relevant rather than an inevitable part of life. Doctors specializing in this area address these concerns routinely as a normal, unremarkable part of clinical practice. Raising a concern directly, even briefly at the end of an otherwise unrelated appointment, considerably increases the likelihood of identifying and addressing an underlying treatable cause. This general subject deserves the same clinical seriousness and freedom from unnecessary embarrassment at 70 or 80 as it does at 30 or 40. The tendency to treat this topic as increasingly inappropriate to discuss with age reflects cultural discomfort rather than any genuine medical basis. And elderly men deserve exactly the same quality of information, evaluation, and non-judgmental support in this area as any other patient, regardless of age. So here's the bottom line. Extended absence doesn't cause physical harm on its own for most elderly men, and testosterone doesn't significantly rise as a result despite common belief. 3 practical takeaways: don't assume reduced interest or ability is simply unavoidable aging without checking, maintain other stress-regulating habits if this outlet becomes less available, and raise any accompanying symptoms with a doctor rather than assuming nothing can be done. If this addressed something you've wondered about, that's exactly why this video exists. The Iron Age Guide is linked with this video. Thanks for watching, and I'll see you in the next one.